Good afternoon. Welcome to Iowa Ideas. This is the ninth year for this conference, which explores topics important to Iowans with a focus on ideas that could help us meet the challenges of today and plan for the future. The Gazette would like to thank the presenting sponsor, ITC Midwest. Their support makes these virtual sessions free for everyone. I'm Erin Jordan, a former longtime reporter at the Gazette, and I now teach journalism at the University of Iowa. I'll be your moderator for a conversation today about the costs and benefits of weight loss drugs. Before the panelists introduce themselves, I wanted to let the audience know you can submit questions for the guests through the Q&A box or in the Zoom chat. We'll try to work as many of those into our conversation as we can today. So I'd like to just start off and ask our panelists to briefly tell us who they are and their connection to the topic of weight loss drugs. Let's start with Haley.
Hi, good afternoon. I'm Haley Holton, and I currently serve as the Director of Clinical Pharmacy at Wellmark. I am a pharmacist by training, and in my role at Wellmark, my team oversees our formulary strategy, formulary development, maintenance, and overall clinical programs within the organization. I appreciate the opportunity to be here with you today.
Claire?
Hi, I'm Claire Harpot. I'm a nurse practitioner with Unity Point Health. I am in the Cedar Rapids area. I've been in healthcare since 1992, being a nurse practitioner since 2015, currently specializing in diabetes and weight management.
Great. Rochelle?
Hi, I'm Rochelle McCabe. I graduated from the University of Iowa with my doctorate in nursing as a nurse practitioner. So I did my graduate project on the disease of obesity. So that kind of got me started. And I ended up with Iowa Weight Loss Specialists. They are with Iowa Specialty Hospitals and Clinics. I've been here for 5 years. I do medical weight management. And so I work a lot with these medications, and I'm really excited to answer some questions.
And last but not least, Steve.
Hi, I'm Steve Simonon. I'm the president and CEO of Iowa Specialty Hospitals and Clinics. I've been CEO for 29 years here in Clarion, and we have a hospital up in Belmont where we do a lot of our bariatric surgeries, and then about 9 outside clinics from Mason City down to Des Moines. I'm also our first patient 11 years ago with the bariatric sleeve, and then I started on the weight loss medicine medications, Zepbound and Mounjaro, about 2.5 years ago. So I've got some experience on both sides, the administration stuff, but also as a patient.
That's fantastic. I'm really just thrilled we have this all-star team of panelists today. So before we get into questions for our panel, I wanted to kind of set the stage. So in 1986, scientists discovered glucagon-like peptide 1, or GLP-1, a hormone produced in the intestine that increases the body's production of insulin and decreases production of glucose. Since then, companies have developed medications that mimic the effects of this hormone to regulate blood sugar and help people lose weight. These drugs, with brand names including Mounjaro, Wegovy, Ozempic, are a game changer for patients with diabetes or others who are facing chronic obesity. That is, if the patients can afford the medications. Rochelle, I wanted to kind of start off with you as a nurse practitioner working in this field. To what degree can these GLP-1 medications reverse course for some of the chronic diseases that come with obesity?
Well, certainly it's highly individualized. These medications are established by the FDA so far for indications including type 2 diabetes, of course, weight loss, we all know that. They can reduce cardiovascular risk, such as death from a heart attack or stroke. They treat now non-cirrhotic metabolic dysfunction-associated steatohepatitis, which is MASH, formerly non-alcoholic fatty liver. And then also they're indicated to treat obstructive sleep apnea. In diabetes, the A1C, depending on which medication the patient's factors, it can be reduced by 1.5 to 2.5%, which can be pretty significant. I've seen much better than that in practice. And there are a lot of studies underway showing improvements in all sorts of health issues. Primarily, these medications kind of open up blood vessels, improve blood flow. So we are seeing improvements in brain health, kidney function, immune, all kinds of things, liver, the gut, pancreas, stomach, just the way everything functions.
Wow, that's amazing, just the cascading effects from, reducing obesity. So there's obviously a huge range, as you said, each patient is individual. But when patients come to you as a nurse practitioner, Claire, maybe you could address this, and they say, well, how much weight will I lose? What do you tell them?
Yeah, you're right. It's each individualized. Everybody will respond a little bit differently to any medication, lifestyle changes. It's all a journey. Typically 5%, sometimes as much up to 25% weight loss, just depending on the person.
So 5% to 25%. And that is, what are the factors that it might be dependent on, the different rates?
It can be the medication, it can be lifestyle changes. It's a whole body process, mentally, physically, and emotionally. So staying hydrated, if they're experiencing side effects, it can just be a whole gamut of things that incorporate into the amount of weight loss somebody may experience.
That makes sense. So, Steve, you've been through the experience of having the bariatric surgery and now that you've had practice using some of these GLP-1s. How was this kind of weight loss? How has it improved your health and quality of life?
Like I said, I had it 11 years ago in 2014. And, I personally, I was just all my story. Personally, I was about 300 pounds. And I got down to about 215 or so. And at 300 pounds at age 50, I felt like I was just kind of dying, in place. I was hurting. And I was an athlete before that. And then after I lost the weight, I got back into biking. We've had a RegBri team now for the last 10 years. I bike every weekend. I just finished a run last week, the Des Moines run with our running club here at the hospital. Got first in my age group. There's only 3 of us. Anyway, it's changed everything. It's like post-surgery. Post-surgery, you have a new life. But then after about 5 or 6 years, I started creeping back up, and Dr. Todd Ibis, our surgeon, started talking to me about the GLP-1s, and that was about 5 years ago. And so when I started on that, I lost another 30 pounds that I originally lost, and it just kind of reawakened a lot of energy and sleep, and my blood pressure was back down, and so it was kind of a new lease on life again.
Have you experienced any side effects of the GLP-1s?
We talked about this a little bit, and so I talk about, and Claire, I think you're going to talk about some food noise and things like that patients experience. I talk to people, and I tell them that a lot of times people stop the drugs because of the cost. They say, well, it costs a lot. And I said, but it's also, for someone who's been on it for 2.5 years, it's like going through life and saying, well, you can't see blue anymore because you don't have an appetite. So you have to kind of get used to seeing things seeing food in a different way, getting to know your appetite in a different way. And so, yeah, that was probably the strangest thing for me, as far as just trying to kind of see reality differently, especially from a guy who likes to eat, and then you take that good friend away.
Yeah. We'll talk about that more, because I think that's a super interesting aspect that I never thought of before thinking about these medications. So, Haley, from a public health perspective and kind of the healthcare costs that society pays through like insurance and other things, and just the cost of hospitals, how do you think that these GLP-1s could change that landscape?
Yeah, it's really a delicate balance of looking at the clinical merits of the drug the real world outcomes that this can have on an individual patient, and then really those economic impacts on society. So when you look at it at that macro level, we're already battling rising healthcare costs year over year. And a lot of that is driven by prescription drug spend. When we look at the magnitude of GLP-1s, that really adds to that mix when we look at healthcare costs and the impacts that that can have. The Institute of Clinical and Economic Review, or ICER, actually published its draft report last month on the treatment of obesity. And within that, it also supports that same notion of there's the clinical aspects of these drugs, but then really the concerns around affordability of these products to treat our patients. When we look specifically at that widespread demand of the product, but then the budgetary pressures that are placed on payers, employers, and even the patient. Looking at, what could an overall cost of this be, just looking at the drug alone, I've seen numbers as high as $1 trillion annually if GLP-1s were provided to all Americans with obesity at current prices.
Wow. Okay, so that's like the cost with the GLP-1s, but is there any sort of like cost benefit of avoiding some of the chronic conditions that are also expensive for the system?
Yeah, when you look at the benefits that the medications provide, it's really trying to look at the long-term benefits and tying a dollar amount to that. Once again, when you look at that at a broader scale, that's really hard to apply to a population, knowing that it's going to take many years to see the benefit that these products can have by losing weight, or, as Rochelle commented on, some of the other indications that these products are now being approved for from that cardiovascular risk reduction. So that's where it ties into that clinical balance of what do we see today? What are those immediate costs we see today? And then how do you apply that long term when we may see some of these outcomes many, many years down the road?
Let me just turn back to Steve for a minute, just on this same question. As the CEO of Iowa Specialty Hospitals, what do you think about the potential financial ramifications of these sorts of drugs on the healthcare system?
I know there's a large cost, but there's also a large cost of taking care of people in the ER, with chronic symptoms that we could have gotten to earlier by making them healthier. I know that I probably wouldn't be in the same place if I didn't have, my experience with the bariatric sleeve or these drugs. I know that there's a lot of health issues in my family that I probably would have had already at 60. I know that there's a large cost on one end, but I gotta feel that there's a savings on the other.
Okay, maybe time will tell in some of this. So when we had a pre-panel meeting the other day, Claire, you talked about how GLP-1s can quiet the food noise in a patient's head. I wondered if you could explain a little bit about what that term means and how the drugs kind of affect that.
Yeah, so sometimes people don't realize the amount of food noise they hear until sometimes that noise is quieted. A lot of times with my patients, I talk about a dripping faucet. When the room is quiet, you can hear that dripping faucet. But when we're busy, sometimes that dripping faucet isn't as noticeable. But when the room is quiet and you hear that dripping faucet, you get up and you try to quiet that drip. Same with food noise. You hear your body can have cravings for certain foods, or you're driving down the road and you see a gas station on the left and Burger King on the right, or a fast food spot or a restaurant. Our society is a lot of times always thinking about food, or even at work, your coworker might have a snack drawer, and your body, your mind is just thinking, oh, that snack drawer is just a reach away, and you don't realize how much time during the day that you're really truly thinking about food, especially people who struggle with obesity and struggle with the ability to control that thought. Many people who add a GLP-1 medication or some type of medication like that don't realize they see a less of that food noise, that food cravings, and they don't realize how loud that noise was prior to kind of decreasing that noise. And then they say it's a whole different life. I'm looking at things that I didn't know were enjoyable around me. I didn't know that I enjoyed exercise. Food noise can make some of those lifestyle changes very hard for people who struggle with a lot of food noise, because their mind triggers right back to that dripping faucet again. You hear it, it's in the background, you want it, you crave it, you want to stop it. So then you eat something rather than deciding, I'm going to go for a walk, or I'm going to spend time with family, or I'm going to enjoy reading a book and opening some new horizons, to some activities or some other things in life you didn't realize you enjoy, with all the amount of time that somebody's listening and responding to that noise.
That's so interesting. Rochelle, do patients that you work with, do they think these medications will be a quick fix? And if so, how do you kind of counsel them about the other lifestyle changes they might need to make?
Yes, quite often. And I feel like a lot of that is social media driven. I tell all of my patients, these are serious medications. They're really indicated for lifelong use. They're not a quick fix. These are the first medications we have that actually address a lot of the abnormal metabolic processes throughout the body. They help function down to the cellular level. And so of course, when you take them away, you lose that effect. But as far as lifestyle changes, I just tell them there are things you should be doing anyway. And I really focus on meeting targets versus taking things away. If you're getting in good nutrition, you're getting hydrated, you're getting your protein and fiber, you're pretty full. There's not a lot of room left for anything else. And as Claire talked about, talked about the food noise, they really shut that down and help people want to eat healthy. So just guiding them on that, and then definitely managing side effects, things that might come up. But as far as when people stop taking them, the studies do show that in real life, if a patient's able to continue on them, the results are similar to what the studies show. But as Haley said, there's a lot of barriers for patients as to why they have to stop them or change treatment course, which is really hard.
Okay, so a couple just quick follow-ups there. So does with it quieting the food noise, does it take away your appetite altogether, or does it just take away the appetite when you really when you really aren't hungry? You know what I mean? Like,
Yes.
I don't know if that makes sense.
Yeah, absolutely it does. So what I tell patients, this is very simplistic, not totally scientific, but in a sense, our brains run off of sugar. So if your brain is stressed, if you're tired, bored, anxious, whatever, your brain's going to kick out food cravings. I tell them it's kind of like your hunting instinct. It kicks in and you are in fight or flight. You want to get energy in your body because you might have to go hide in a cave for a long time. You need that extra fuel, fat mass to live off of. And we have these animal instincts that we don't really need anymore. But yeah, a lot of patients just feel like I don't have that feeling anymore. And a lot of that, I think, is just better nutrient exchange, better support to body tissues.
I like that idea that when I'm stressed, I just want to go hide in a cave. So that
Well, you want to live.
Right. So a question from the audience here. They ask, is it true once you stop the medication, you will typically gain the weight back? I don't know if our nurse practitioners want to weigh in on that.
Yeah. And as I mentioned, when you stop the medication, you lose the metabolic effects that the medication was providing. I don't know if Claire has a lot more to add to that, but yes, it is expected that you will gain back probably if you stop taking the medication. Even I have a lot of patients that come in and they're doing everything they should be doing. And diet and exercise and lifestyle doesn't always equate to a healthy weight. There's genetics, there's all kinds of other factors that come into play. And the medication really kind of addresses some of those underlying issues.
Yep, I agree. A lot of times when patients do have to discontinue the medication for some reason, some of them see a lot of weight loss, a lot of weight gain again, and other people it's not as quickly. Everybody's individualized, but I always tell people as well that this may be a lifelong medication, and these are the steps that you may need to take in order to continue with seeing the benefits from the medication.
Steve, I want to turn this to you as kind of our patient here, also in the room. Did that idea of taking a medication for life deter you at all, or how did you feel about making that decision?
I was talking with my one of my docs about it, and he said I take cholesterol medicine for the rest of my life. I didn't take high blood pressure medicine for the rest of my
Yes.
life. And I think the drugs come in different in different levels, prescriptions and things. So to get onto kind of that moderating level, so you're not always going to have you're not always going to push it up if you're going to basically maintain the lifestyle or the weight. And Haley, I'm going to look to you as a pharmacist. Is that kind of right?
Yeah.
I mean, if I wanted to continue to lose weight, I'd probably increase the script, right? Or
Yeah, so there's a couple of variations there. I mean, I think the hard part is that everyone is individual once again, right? I mean, these products come in a variety of doses.
Yeah.
And the way that the products were studied was at a very rigorous and calculated dose increase adjustment. I think real world evidence might show different things when we get into that individualized patient journey, because not all patients are created the same. And so while one patient may need to be on a max dose for the lifetime, maybe another patient might be able to back down on their dose and still maintain that healthy weight loss or maintain that weight loss that they've achieved. And so I do think it does bring in that level of really that patient-centric approach on what's best for them.
Aaron, can I ask Haley another question?
Go for it.
They're coming out with different types of doses, though, right? Like on a daily versus a weekly, or is that going to change?
Yeah. So I can jump maybe to some of the pipeline that's coming out. Is that where you're going, Steve?
I think so.
Yeah. So with that, there is a variety of different doses in the pipeline, whether it be different dosing intervals or different formulations of the product. I think the big one that it comes to where there's a lot of excitement is currently all the products available are injectable formulations. And when we think about a medication being forever, in the analogy to the cholesterol medication, that a pill may be more palatable than an injectable product, especially when we look at injections might be a barrier to even access for many of our patients that would qualify for these products. So I think the most exciting part as a pharmacist, when you look at the science, is just the way that the products could become available in different formulations, and an oral product is coming in the pipeline. And that does seem to be perhaps maybe a more palatable long-term option for those that are looking at this as a chronic medication.
Great. Well, and we, maybe can talk a bit more about that too. I just have a couple other questions related to that we can talk about a little bit later in our panel here. So I wanted to hit on one of the main themes of this panel discussion is the cost of the weight loss drugs, the GLP-1s. So I had just doing a little online research. It looks like I had seen some commercials and other sites saying $500 a month out of pocket, if that's how you're paying, to more than $1,000 a month. I don't know. Does that range of costs sound right to the panel?
Well, I can definitely speak to that. That is one of the main concerns of patients is, does my insurance cover it? And if not, what do I do? Right now, the manufacturers are aware of that, and they have been really trying to offer affordable cash prices. So right now, there's an option that most of the doses are $499 cash pay through the manufacturer, or with some special coupons and such at the pharmacy. So that's what they have done to try to bring the costs down. I know that they are also trying to bargain with employers' insurance coverage to maybe increase the patient's co-pays to kind of bridge that gap for everybody.
Interesting. Anything else from does that upper range of 1,000 or more per month, is that true for some of the medications?
If they don't go through the manufacturer direct, then yes, some people can pay up to sometimes in excess of $1,000 a month. But usually, as a provider, we're trying to help direct them to other more cost affordable or more affordable ways of, if this is a tool for their weight loss journey and may help their weight loss journey, we're looking for those different opportunities to make it more affordable for the patient themselves.
A lot of the manufacturers also offer assistance programs for patients in financial need as well, especially for the other indications besides just weight loss.
Okay. So Haley, turning to you as working with Wellmark, the largest, I believe, insurance company, health insurance company in our area, for which medical conditions would insurance companies and other payers like Wellmark typically cover GLP-1s for?
Yeah, so GLP-1s, when we think of the whole portfolio of products, we do have the GLP-1s that are FDA approved for type 2 diabetes. Those are a mainstay on most payer, all payer formularies when we look at covering the products specifically for diabetes. Indication typically is going to come with a prior authorization requirement to limit the use of that product to those patients who do have diabetes. When we look broader, though, to the GLP-1 market used for weight loss, we really see a variation in coverage availability across the market and across different payers. Specifically at Wellmark, we do cover GLP-1s for diabetes, and we do cover for the cardiovascular conditions or cardiovascular risk reduction. When we look broader into weight loss, our self-funded employer groups can make their own coverage decisions and may choose to include coverage for other indications, including weight loss, once again, subject to prior authorization criteria. I will say that it is a very highly dynamic space when we look at GLP-1s and coverage among payers. It is something that is a very common topic among health plans. It is constantly being reevaluated as new evidence comes to market, as new indications come, or new products are coming down the pipeline. So it's just a very highly changing environment.
Let me ask, so when you said that some of the GLP-1s are specifically for diabetes, which ones are those?
Yeah, so Ozempic, which is similar when we think of the core product to Wegovy used for weight loss, Ozempic is FDA approved for type 2 diabetes. On the same vein, Mounjaro is the type 2 diabetes. And then on the weight loss side, we would have Zepbound. So you've got two similar kind of base drugs being used for two different FDA approved indications. So really Ozempic, type 2 diabetes, but Wegovy is for weight loss, cardiovascular risk reduction.
Okay. So let's say you have type 2 diabetes and you want to get approved by your insurer to use Ozempic. Would that pay for the full costs or would it just kind of offset the costs?
It really depends on the benefit plan design for that individual patient. There are a variety of different plan designs that may be provided. There are copays where it may be placed on a tier with an associated copay. There may also be high deductible health plans where you may be responsible for the full cost of a product until you reach an out-of-pocket maximum, and then you would have a reduced or waived fee. So it really is individualized to that particular patient.
Okay. Just kind of turning to Rochelle and Claire, what are you seeing, as you try to help your patients find the right prescriptions, if prescription is the right path for them? What are you seeing or hearing from them about costs?
Again, it's very individualized. One patient comes in, 1 hour and it's covered with a $25 copay. And another patient comes in and we have to submit to the manufacturer and they're paying $499 a month. So it is very individualized with as much, again, as we've said previously, that people see on social media. They hear from other people, their neighbor has had a success journey with one of the medications. They want the exact same medication and they want the exact same results. And it is just a very, can be a very tense and emotional conversation with the provider and the patient, making sure that they understand the journeys. And a lot of emotions are involved. Money is very emotional. It is when some people can afford more things than other people, and having that conversation with each individual person. This has to be cost. It has to be affordable for you. You have to tell me when this is not affordable and this isn't meant for my journey at this time.
Yeah,
Michelle,
and
is there anything? Oh, go ahead.
it's an ever-changing playground as well. I'll have patients come in 1 month and it's $25, and then they come in the next month and they're like, my copay is going up to $200 or $500, or they're losing coverage. Or sometimes the insurance company will change their formulary and they'll be on, say, Wegovy, and now they can't get that anymore and they have to switch to Zepbound. So switching back and forth. And these medications technically are not interchangeable. They have different indications that they've been studied for. So if I have a patient on one for one indication, but it's not covered anymore, that can be really upsetting for the patient, for sure.
So throughout history, we've seen drugs, oftentimes cost a lot right when they come out, especially if it's a brand new brand name drug, and then the costs come down later, especially, maybe some much later. I don't know when generics are available. Haley, I don't know if you, with your pharmacy training, would be able to speak to what that timeline might look like for costs.
Yeah, I'll say there's no crystal ball, but kind of looking at history of drug pricing trends, it would highly suggest that we do start to see a reprieve in pricing as generics or biosimilar versions of products come to market, or additional competition comes out. When we look specifically today at the Ozempic, the Wegovy, the Zepbound, they won't lose patent or exclusivity until the 2030s. So we are looking a bit down the road. That being said, some of our older GLP-1s that are used for type 2 diabetes will start to lose exclusivity in the next 2 years. I think the other big piece to keep in mind here is that competition. So as additional manufacturers are racing to come out with their version of the product, bigger, better versions, the oral products, that's also going to have a huge impact on pricing. And that's where, we're all hopeful we'll start to see a bit of a change there.
So might it be something like the oral version costs more, but if you're willing to still do the injection, you might get it for a little cheaper price?
I guess I'm not the expert on reading what that would be like. However, once again, you might see when you look at the development of drugs too, sometimes that comes into a piece. You also have to break it down into how are drugs priced? Why are they priced so high? Oftentimes you might see an oral product actually costing a little bit less because that research and development that goes into creating or manufacturing that product may be less than it would be to create that injectable version. Once again, these are generalizations and, don't have that crystal ball, but trying to take some of what we know in the past and apply that forward.
Makes sense. So we have another question from the audience, and this is very specific, and I don't know exactly what all these levels are, so maybe one or both of our nurse practitioners could weigh in. But the audience member says, I have pre-diabetes with an A1C of 6, but my insurance won't cover the drug since I'm not over 7. What should I do to be proactive and use the drug sooner?
So for diabetes, usually it would be 6.5% or higher. So they are not FDA indicated for pre-diabetes. So that is a really upsetting thing for a lot of patients, is they maybe have what we call metabolic syndrome. They're sick. They've got hypertension. They have diabetes or pre-diabetes. They have high cholesterol. Maybe they even have mild fatty liver. And so a lot of them are frustrated that they can't get covered more preventatively. They have to wait until they're sick. And that's a whole thing with our healthcare system is we're struggling to keep up with people who are very ill. And so I think it's important to know as new medications come out and the prices come down, they'll get more accessible. More people will be using them. It's kind of it's a new thing. It's exciting right now, but hold tight. I tell my patients, eventually they will probably come around.
I also say celebrate the fact that you don't need a medication at this point.
Yeah.
In my opinion, less is best. Don't, some people strive to use a medication, and then once they initiate the medication, they have these significant side effects, and it wasn't meant for their journey anyway. So celebrate the fact that you don't need a medication at this time. Celebrate the fact that you are able to have one less thing that you have to remember to do every day or once a week, and look at it as more as a positive aspect of your journey versus I can't have and feeling like I can't have, I'm going to get sicker quicker. The mind is a powerful thing, and sometimes that will lead you down the pathway of becoming more ill or quicker. And we want to celebrate those, we want to be able to celebrate those positives rather than being, a lot of times we are in a negative world for many negative reasons. So celebrate those positives and celebrate the fact that you don't need it at this time.
I love that
Absolutely, Claire.
perspective.
Yes. And I call that with a lot of patients, they will be upset they're not losing weight as quickly as they wanted to, whether they're on a medication or not. So
Yep.
looking at those non-scale victories, I tell a lot of patients it's not at all a vanity thing. You want to be healthier. So I'm saying, if we all couldn't see each other, what's bothering you about your weight right now? And it's maybe their knees hurt or whatnot. So there are a lot of other things we can do, like referring them to therapy, like physical therapy, just working on meeting good nutritional targets and things like that. Though with pre-diabetes, to answer that question a little more specifically, if they feel like they're doing everything they should be, they're just struggling. There are older oral medications that treat diabetes that are often will go through and be covered for pre-diabetes now too. So there's other options besides just the GLP-1s.
It's also being honest with yourself too. We were talking about the food noise earlier. People don't realize that they hear that food noise. They don't realize I've stopped 5 times this week to go through a drive-through, or I've had to fill my car with gas 4 times this week. And I've gone into the gas station and I've come out with 3 candy bars and a sugar pop, or, something that has calories or carbohydrates in it that can affect, us storing that for, we were talking about hibernation. If we're in that hibernation mode, we're storing that for when we need fight or flight. And so our body identifies that as, oh, it's not what we need right now. We must be thinking about something we might need it in the future. Let's store it. And then that's when we can see those pounds creep up, or that's when we can see those blood sugars creep up, or that insulin resistance happen a little bit more. And then it's like a domino effect, and we want to stop that domino effect.
That's great to know. So lower income and minority populations are disproportionately affected by obesity. That's what many years of research have shown to be true. So lower income folks are also less likely to be able to access the medications that are expensive, including right now, a lot of the GLP-1s. I wanted to just kind of put it to the whole panel. Maybe I can, hear from each of you. What are some ideas that are out there to get these medications to the people who need them most?
That's a tough one. Sometimes there just isn't an option, and it's just not, not able to get out to some people that need it the most. It's a whole nother topic, but people who struggle with insecurities rely on others to help provide food. Those foods that are more affordable can be the foods that might not be the best choices for us, but those are the only ones available. High carbohydrate foods, macaroni and cheese, those things like that can be $2 to $5 a box, whereas something protein related or fresh vegetables are just out of the range of anybody with, in that lower economic sector there. And so it may not just be an option, and that's the hard part, and that's the they still have social media and TV available to them and see this being put in front of them all the time, and why can't I? And sometimes it's just not an option.
Yeah, Claire, I'm the president of the Iowa Rural Health Association, and one of the things that we've been looking at for the last couple of years in the rural areas, it's even tougher because there's not access to healthy foods all the time. Nothing wrong with them. We have Dollar General. I just went there this morning, but we don't have access to a lot of the good food pantries and the good healthy foods. And one of the other things I was going to talk about, and I think, Rochelle, you mentioned this on physical therapy, we also want to be pushing mental health therapy, and we want to be pushing our diet. We have a lot of dietitians. Our society, and Claire, you touched on this, our society is at the point right now where we're not educated. When we're hungry, we eat a Big Mac, and we're, as opposed to sitting back and saying, well, maybe I can have an apple like they would have 20 years ago. It used to be a special thing when I was growing up to go to McDonald's. Oh my gosh, that was a great thing. Not an every other day thing. And that's why we're lucky in the rural areas, because we don't have McDonald's. We have one stoplight and no McDonald's. So, it's a healthy thing, I guess.
Yeah, and I'll kind of echo Steve there, more from a pharmacist perspective. But we think that sometimes the medication alone is the answer. But when we look specifically at these weight loss medications, it's multifaceted, and the weight loss medication alone isn't the answer. It really has to be paired with some lifestyle integrations. And so really setting up our population for success when they embark on a weight loss journey, and adding in that behavioral support, the nutrition support, and really continuing that along the way. It's not a one-time thing either. It's all along the way. It's a partnership together. And I think that needs to be stressed a little bit too, and that the drugs itself are not the answer.
Right.
Yes, absolutely. And I'm seeing a big trend too in patients who are getting more interested in more natural remedies, improving their nutrition and their food quality. And so I think there's a big push towards that direction as well. Not only using the GLP-1s because you need them, but they're trying to find what is the root cause? Why am I struggling with this in the first place? And they're really questioning that. And the cost of these medications has really brought that to the forefront.
Some of the solutions I'm hearing potentially are looking at some natural remedies, looking at the root cause of that appetite that causes you maybe to overeat. Maybe working on some of these other societal issues like the food desert problem we have in rural areas, so that there's greater access to healthy foods. And then just wanted to hit on one other thing you mentioned earlier, is just some of the discount programs offered through the drug companies. Do you think the drug companies have some more potential to expand those discounts to to lower income groups?
They try to. A lot of it is the way our health system and billing and things are set up, that big corporations buy the medications in large quantities. I'm sure Haley knows more about this than I ever would, but it's a retail system in our country. And so it's really hard to put money aside that way. But the drug companies do try to help bridge that gap when they can. And just the offering of the cash option, when the retail price, I know at one point Wegovy was $1,600. Now they're offering it for a cash price direct to the consumer for $499. So that's pretty significant savings there. But really, as more medications come out, there's more to choose from. They get more mainstream. They're around more. The prices just seem to come down over time.
Okay. So question from the audience, and this fits with something I had seen recently. I saw a commercial for one of the GLP-1s, and it said repeatedly throughout the commercial, ask your prescriber instead of, ask your doctor or, your healthcare professional. But the question from the audience member, are companies like Hims and RO is it safe to buy the GLP-1 drugs there rather than through like a more traditional healthcare provider or pharmacy?
So the compounded medications are not FDA approved. The pharmaceutical ingredient that is used in those is not studied at all. So I tell patients, if you're thinking about those medications, there's not really any oversight for them. They might be manufactured in a good compounding facility. They're sterile and they're safe that way, but you don't really know what that molecule is. The FDA hasn't looked at them to design criteria that says, is this close enough to be called semaglutide? I often, for patients, I'll draw a nice, perfectish star on a paper, and then I'll draw kind of one like a 3-year-old drew it. And if I'm a scientist, but I'm not really well versed in GLP-1s, or I'm trying to do a good job, I might say that they're both great stars. But then when the FDA looks at it, they may say that star is not close enough to be considered the same efficacy and safety as that other star. And so I would be hesitant to that. Other older generic medications that are compounded, they've been around. The FDA has set those parameters for them. And they're generally, the compounding is meant for a patient who needs a special adjustment to a medication that's otherwise not available to them, not to manufacture medications that are already out there with an FDA label under patent, essentially.
Interesting.
From an Iowa Rural Health Association, support your local drugstores too. We need our local drugstores. We need our local healthcare people.
Yeah.
Whereas some of these other companies they don't have like a local brick and mortar location or that sort of thing. Is that what you mean?
Yes. And the products that they are selling they're not necessarily the legit molecule that is out there in the FDA approved brand name medications. And there's not really any system in place to prove whether they are or not for sure.
Got it. So use of GLP-1s is relatively new, at least some of the more modern ones. I take that. And research is promising about the long-term benefits for people who use these drugs to keep off weight that may be causing chronic health conditions. But there's also some indication there may be long-term use could increase risks for pancreatitis and kidney conditions. This was according to a study published in January in the journal Nature Medicine. So, Claire and Rochelle, how do you talk with patients about the potential risks when there's so much unknown about these long-term impacts? Claire, do you want to start us off?
Well, with any medication, there's always a risk of any side effect or any complication. So you, as a prescriber, I have that in-depth conversation with them so they know what to expect and what to do if they experience any of those. I think the prevalence of pancreatitis is minimal if used in the right situation. So, we always have to look at the person as a whole. If they have high triglycerides, it's less likely we're going to use this medication. They might be more at risk for the side effect or for a complication of pancreatitis. There's other things that you look for as a whole too. Alcohol consumption. If you have higher alcohol consumption, you're putting yourself at a higher risk of pancreatitis with use of this medication. So again, every journey is personalized and should be looked at the person as a whole. If there's a higher risk of pancreatitis, it's less likely that this medication would be one that I would choose to prescribe for a patient.
Yeah. And to add to that, these medications have actually been around for over 20 years.
Yes.
So the potential side effects are pretty well known. And I want to say, kind of going back to like the hims and hers and such, the side effects are really generally well managed with adequate guidance from an experienced provider who knows how to guide the patient, is following up with them, seeing them in the office. evaluating what are your food choices that you're making that may be impacting your side effects. What are your eating patterns? Are you skipping meals? Are you eating too often? Are you eating before bed? Are they well hydrated? If a patient comes in, they're not hardly drinking any water, I'm going to say you need to get hydrated before these medications can be started, because that can damage your kidneys. Your kidneys need hydration to function. And also, making sure that they have regular bowel movements. I put a lot of people on kind of a bowel management program to make sure that they stay regular, because they could get a bowel obstruction. There's all kinds of things that can happen. But with the right diet, nutrition, lifestyle, monitoring them, as Claire said, looking at their other risk factors, that's really important. That's why they really should see their provider for these types of medications.
And the medications will decrease your appetite, but we do not want that appetite to go away, because your body still needs fuel. Regardless of what
Absolutely.
happens, your body needs fuel. And, you know, there's high risks of losing weight too quickly. So if you lose the weight too quickly, then you're putting yourself again at higher risk for, you know, gallstones if you have a gallbladder, and again, an increased risk of pancreatitis. So slow and steady sometimes wins the race. You don't want to be 30 pounds less in 1 month. That's not normal. And if that's what's happening with any medication, we want to look into the reasons why and make adjustments and not titrate up and maybe titrate down. And so there's a lot of factors that go into use of any medication, but especially with the GLP-1 medications.
Absolutely. And I tell patients, you know, you got to start low and slow and escalate these per the schedule or slower, manage the side effects as you go, and definitely being careful, being monitored by your provider as you go. Our office, we actually have I don't know if Claire does body composition. Otherwise, you can send patients, if you don't have that, to get like a DEXA scan to look at body composition, but we make sure they're not losing a lot of muscle. They're mostly maintaining muscle, primarily losing fat mass. We check their waist measurement, energy levels, all sort of things that go together with that.
So I wanted to ask Steve, you know, as the CEO for Iowa Specialty Hospital and Clinics, what would you expect your facility's operations to look like 10 years from now with more regular use of GLP-1s? Do you think it's going to be a significant change? What might you imagine?
You know, I talked to one of my docs about this, and he was talking about, you know, primarily we started off doing a lot of surgery is before the drugs, and we were talking about surgery the other day, and he said, you know, we've seen a huge decrease in the amount of patients that we do bariatric surgery on with the increase of GLP-1s, and I said, what do you think the long-term trend is going to be on that? And he says it's probably going to even out. It's probably going to go back, because the amount of people that we treat with either GLP-1s or surgery is very small in the population compared to how many people are truly obese, and the population isn't getting any thinner, you know. Unfortunately, you know, as much as we're talking about a lot of this stuff, there's still an increase in the obesity rate. So I think we're going to be dealing with this for ever, you know. But who knows? I mean, this stuff's changing on. Haley, you can talk about it. This stuff's changing on a daily basis. It's crazy. You know, who would have thought that we'd be here, you know, a couple of years ago? Who can say what's going to happen in 10 years? We're just hanging on and enjoying the ride.
Well, and obesity is chronic. You know, it's ever changing. And what we were doing, we've said this before, 10 years ago, has changed. Medical research has changed. So healthcare, we have to expect change. If you're not willing to change, then you might not have a good future. But as healthcare providers, all of us here on this panel, and pharmacy, we are ever changing, and we go with that change. So
Well, and I think just to some of those points there, I think I was reading that Iowa's obesity rates it's one of the highest in the nation, and you know that. So we face that challenge. It's not just Iowa, Upper Midwest, I think has a lot of challenges there. There was a study that was done by a company called Real Chemistry where they looked at records for a bunch of different, patients that had names taken off, obviously, and were able to determine the states with the highest use of GLP-1s. And I think the highest was the state of Kentucky at 1.9% of the population using GLP-1s, but Iowa was not far behind at 1.5%, and the lowest was Hawaii at 0.4%. And, I don't know if I could just throw this out to the panel. Do you think that might be related just to our share of residents who are obese? Or do you think that is it hard to know for sure how that correlates?
Honestly, I think a lot of it's multifactorial. It could definitely be socioeconomic. I have a surprising amount of patients who pay out of pocket for their medication. Also, some states, actually, their Medicaid program may cover these medications, so the use may be higher. It would vary by different programs, employers. Some of them will set their prior authorizations to be a little stricter than what the FDA allows to kind of contain that use. And other places it's more liberal. So it really varies that way.
Lifestyle is vastly different from Hawaii to Iowa as well. We have several months out of the year where we typically aren't outside because it's too cold, whereas Hawaii, usually majority or all of the year, you have other opportunities versus Iowa. When it's 30 below zero, all we're doing is hunkering down inside watching TV, or some of us are relying on comfort foods during those months as well. So vastly different lifestyles.
Yes. And like genetics, depending on where you live too. Hawaii compared to Iowa is vastly different. Also cultural things. What dishes does your family enjoy? What holidays do you celebrate? And yeah, it's interesting to compare that, but there's so many different factors. It's hard to really measure
all
it
in
out.
the same bucket. Yeah.
Okay, just with our last couple of minutes, I just wanted to ask the panel, we've talked about how GLP-1s are not a silver bullet. That it's not just a quick fix. What are some lifestyle changes medications aside, that Iowans should probably be focusing on, whether GLP-1s are in their future or not?
It's okay to say to not clean your plate. It's okay to not get that extra large pop from the gas station that's 89 cents, and maybe it's more realistic to pay 99 cents for a little bit less. Dinner plates are definitely bigger than what they were 5-10 years ago, so transitioning from dinner plates to salad plates, just making some of those choices for you, and using the tools in your toolbox that you need to achieve some of those goals, those non-scale victories, those goals that you wish to achieve.
Yeah. And I think too, focusing on getting in good quality nutrition, trying to meet your protein target, your fiber target, your water intake target. If you're doing that, you're going to be too full for other things. And I tell a lot of patients, our brains kind of associate flavor with nutrient value. So if you're eating a lot of low value foods, the good foods that are nutritious and nourishing aren't going to taste as good. And so I just had a conversation earlier with a family, and I said, you just need to get those things out of the house. The kids are going to eat them because they taste good. They don't understand nutrition. And so it's a lot of family counseling, just different lifestyle changes that can be difficult, but focusing on what you should do sometimes reins in what you shouldn't do.
Eve, as our patient on the panel, what do you think about things that have helped you be successful?
Take advantage of the bike trails in Iowa. We've got a fantastic system here. Take advantage of it. It's fun.
Yeah. Well, that ties in also to mental health. Get outside and move around. Find something enjoyable you do. I tell some patients, they're like, I don't like to exercise. Dance in your kitchen. Skip around your table.
when you're watching TV, tap your toes when somebody's walking, or touch your knees when somebody's running, or kick your legs out when they're talking on TV, having a conversation. That also keeps your brain busy, and you're not focusing on that food noise and giving into that food noise and getting up and having that snack.
Yeah. Or finding a little hobby that keeps your hands busy, like knitting. I told one man, I'm like, maybe you can whittle some little figurines or something. So, yeah.
And I'll add in from the payer perspective, don't underestimate the power of that lifestyle integration, and really make sure that you're capitalizing and leveraging other resources that are available to you. And so it may be disappointing if a drug isn't covered, but look at other resources. So I know at Wellmark, we offer many of our members access to health and wellness discounts, nutrition counseling, virtual care, other ways to support that holistic weight management that really can be powerful, and really, really capitalizing on those different resources that are available.
That is amazing advice, and I'm so happy to end this panel with that. I'd like to thank our panelists so much for participating today. We've got Rochelle McCabe and Steve Simonon from the Iowa Specialty Hospitals and Clinics. We've got Claire Harapat from Unity Point Health, and Haley Holton from Wellmark. Thank you so much, you guys.
Thanks, guys.
Thank
Thank
you.
you.
The next session on the healthcare track of Iowa Ideas is about the cost of prescription drugs and pricing transparency. So if you've ever wondered about pharmacy benefit managers or PBMs, this session is for you. It's tomorrow morning at 9:40 a.m. Central, if you want to join us for that conversation. Thank you to ITC Midwest for being the presenting sponsor of Iowa Ideas, and thank you to you, the audience, for joining us today. Thank you again. Have a great evening.
Okay, and I think we're clear.
All right.
That sounded excellent. Thank you, everybody.
Yeah,
I know you kept my attention with all the questions and answers. I thought that was great.
It was good. I appreciate the opportunity for being part of the panel. Thank you.
Yeah,
Yeah.
thanks.
Yeah.
Did you
And-
guys feel like you were able to share your primary points, like that you got the message out?
Yeah, I feel like Claire and I probably had the same primary points and we probably could have filled hours with all of our knowledge.
It's a passion, and
It's a lot.
I can tell people I can talk about it until the sun comes up next week.
Yes, yes. I often in social situations, I end up giving presentations by default.
Well, it was nice to have both of you because you both have just, like different ways of talking about it. And I liked hearing both of your insights.
Well, I appreciate it. Thank you.
Yes, thank you very much.
Yeah, and I just want to call in, I think from the payer perspective, it wasn't the purpose of the topic today, but we're all going for the same common good, right? We all want what's best for our patients. And I do think really just the collaboration among payers and providers is a passion of mine. And so I think this, for me too, or bringing Wellmark in was just really good for us as well, because we want to be their partner. We don't want to be a barrier. And so, as I say, it's a rapidly evolving pace, knowing maybe some of you now, perhaps we could engage outside of this platform as well and stay connected. And so probably not the purpose, Erin, but I'm going to put that plug in.
No.
I do think this is a partnership to be successful. We're not on islands. And so
Absolutely.
I just want to put that plug out there.
Yes, and I have that conversation with patients quite often, that insurance companies need to protect your employer and your copay and your out-of-pocket costs. They are trying to balance it out. And our population, a lot of us, there's a big scale that these people are very, very sick and expensive. These people are okay. We're making it. So try to work on all of those things that you can do to help yourself in the meantime. And Claire did an excellent job digging into that. And that's a very important piece of it.
Yep.
Well, and coming together as a team for the
Yes.
future, and nobody's a bad guy. And
Right.
patients always want to blame somebody. And when we don't have the people, all of us coming together as a team and seeing the payer versus and the prescriber coming together and saying we're trying to accomplish your end goals, and we're doing the best that we can for you.
Mhm.
Yeah.
It's great. It'd make me so happy if you guys stayed in touch. So thanks so much.
Yeah.
And
I'm
anything
happy
else you
to.
need from us, Tim?
No, I want to thank each and every one of you for your time today. I know sometimes it's hard to make time in our day because we get so busy, but I appreciate all the time and effort and all the knowledge that you shared with everyone today.
Thank you so much.
Yeah,
Thanks so
Thank
much.
thanks,
you.